Hello everyone. So this is a new video, and in this particular video we would be continuing with the CNS unit, and specifically the status epilepticus part. We would start from here and we would see how many topics we could complete in this 4-hour session. So let's begin the timer. So in the last video we stopped at precipitating factors of status epilepticus, and in this video we shall be beginning with pathogenesis. So epilepsy is mainly an excitatory state in the brain. So excitatory, when does it happen? When there is failure of inhibitory mechanisms, and there could be excessive excitatory neurotransmitters. There could be loss of inhibitory neurotransmitters. Examples of these neurotransmitters include glutamate for excitatory and GABA for inhibitory. And overall, this fits into the logic, which is failure of inhibitory mechanisms, meaning lots of excitation. Neuronal damage occurs 1.5 to 2 hours of continuous seizures. So it is very important that we treat this particular condition promptly. Associated complications of this status epilepticus includes hypoxia, hypotension, cerebral edema, electrolyte imbalances that worsen the electrolyte imbalances can worsen seizure threshold. So seizures can start happening at a lower neuronal activity depending upon what the electrolyte state is. So next we learn about the investigations. So we have things like blood chemistry, biochemistry, blood gas analysis, lumbar puncture, EEG and imaging. So in blood biochemistry we look for glucose, electrolytes and renal function tests. So with this we see if there is anything that is causing an issue to the brain. So all of these things, urea, electrolytes, sodium, especially sodium and calcium and glucose, like a lot in a very high number, very high level or a very low level, can have bad effects on the brain. Then coming to blood gas analysis, it is done to assess the acidosis. And then there is lumbar puncture. Lumbar puncture if meningitis suspected. As we all know, meningitis can cause seizures. EEG for non-convulsive status epilepticus. So if you don't see the movements like directly, what do? You can check using EEG. And neuroimaging if trauma or tumor or structural brain deformity is suspected. So these are the investigations. Next, coming on to the management, treatment of status epilepticus. So this is a very important section, and all the doses with all the drugs need to be remembered in detail. So first, 0 to 5 minutes, initial observation and emergency measures. So over here what to do is just like every other emergency, ensure airway patency and intubate if necessary. Administer oxygen because it's important. IV access for glucose and electrolytes. So we have seen over here what are the possible risk factors and what we need to check. So make sure that we have everything in place to get those things in order, and monitor vitals to check what the status is. And these are the 4 things we need to do. So repeating again, ensuring airway patency, administering oxygen, IV access for glucose and electrolytes, and monitoring vitals. Next, 5 to 15 minutes, first line drug therapy, lorazepam, midazolam, diazepam, and then if nothing works, repeat dose. So IV lorazepam is the first line, 0.1 milligram per kg, maximum 5 milligrams at 2 milligram per minute. 0.1 milligram per kg maximum 5 milligrams at 2 milligram per minute. IV midazolam, it is 0.1 increase 0.2 milligram per kg, or IV diazepam 0.2 milligram per kg, maximum of 10 milligram at 5 milligram per minute. So here it was 2 milligram, here it is 5 milligram. Next, if no IV access, so all these were IVs, the IV access is not possible, we go for rectal diazepam, which is at a higher dose. Why? Because of bioavailability issues. So 0.5 mg per kg. So rather than, instead of doing 0.2, we are doing 0.5. Or intranasal, so this was rectal if IV access is not available, otherwise it intranasal midazolam 0.2 mg per kg. So intranasal 0.2 mg per kg, 0.2, 0.2, repeating everywhere. Next, if seizures persist even after 5 minutes. So repeating, then you reach the 15 to 35 minutes. Then we have the second line drugs. What are the second line drugs? Phenytoin, fosphenytoin. So over here, phenytoin, it is given IV 20 milligram per kg at 1 milligram per kg per minute, and IV fosphenytoin is the same dose, 20 milligram per kg PE at 3 milligram kg per minute. So the dose is this. Let's see what PE is. Phenytoin equivalents. So same thing, phenytoin equivalent. This is a phenytoin equivalent. What else? Yeah, the same thing, PE. So next, coming to 35 to 60 minutes, third line therapy. So 35 till 35 minutes, it's not working. We go on to the next, the third line. So repeat phenytoin, fosphenytoin. So we are already giving it in the second line, but right now what we do is we increase the dose from 5 milligram per kg to up to 30 milligram per kg max. Next, IV phenobarbital 20 milligram per kg at 2 milligram kg per minute. So this one itself 20 milligram kg per minute. So this one, it is a range from 5 up to 30. So 20 to maximum 30 milligram per kg maximum. Phenytoin, fosphenytoin from the second line. Then the IV phenobarbital, that is 20 milligram per kg at 2 milligram per kg per minute. So phenobarbital, marbital. Then there is IV valproate 20 milligram per kg bolus over 5 minutes, maintain at 5 milligram per kg per hour. Then finally we have mannitol infusion 5 ml per kg over 10 minutes. 5 ml per kg over 10 minutes. Previous one was 20 milligram per kg, 20 milligram per kg bolus over 5 minutes. Mannitol is 5 milligram per kg over 10 minutes if cerebral edema is suspected. But if it keeps happening even after 60 minutes, refractory status epilepticus, where we need to do continuous EEG monitoring, IV midazolam infusion and dose escalation is needed. So midazolam coming from first line therapy, midazolam, and you keep increasing the dose. And other sedative agents include phenobarbital with the same dose over here. Where is it? Phenobarbital thiopentone, so this is a new drug, 5 to 10 milligram per kg, so half of this, 5 to 10. Propofol, slightly lower than this, 1 to 3 milligram per kg. I'm not sure about this, it's very hard to remember. Yeah, so this is the management. So once more, the treatment 0 to 5 minutes, 5 to 15 minutes, 15 to 20 minutes, 35 to 15 to 35 minutes, 35 to 60 minutes, then after 60 minutes. So initially we do the emergency management, observation and all that, and ensure that vitals and we have the right place for IV access. And then 5 to 15 minutes first line therapy, IV lorazepam, IV midazolam or IV diazepam, 0.1, 0.2, 0.2. Then if there is no IV access, rectal or intranasal route, which one? Diazepam, midazolam, 0.2 for midazolam, 0.5 for diazepam, and repeat dose every 5 minutes if seizures persist. But even after 15 minutes, if they don't go away, we go for second line. Second line we have phenytoin, fosphenytoin, both are IV and both are 20 milligram per kg. Then there is 35 to 40 minutes. If this doesn't work, then third line therapy is initiated, and it includes the second line drugs, phenytoin, fosphenytoin, and it can go up to 30 milligram per kg. Then if that does, and in addition to that, start IV phenobarbital, 20 milligram per kg. So 20 milligram per kg. Then IV valproate. So this is a new drug, 20 milligram per kg, and mannitol infusion 5 ml per kg over 10 minutes if cerebral edema is suspected. Then after the 60 minutes, if still not working, EEG monitoring, IV midazolam infusion and other sedative drugs like phenobarbital, thiopentone and propofol. Complications of status epilepticus, as we have seen earlier, 1.5 to 2 hours continuous status continuous of convulsions can lead to various issues. So cognitive impairment, behavioral disorders, chronic epilepsy, and systemic complications include respiratory failure, electrolyte disturbances and multi-organ dysfunction. Cognitive impairment, behavioral problems, chronic epilepsy, and systemic include respiratory issues, electrolyte issues and multi-organ dysfunction. So with this we come to the end of discussion on status epilepticus. Now coming to CP. For that, let me drink some water. So definition: CP, cerebral palsy, is a non-progressive neurological disorder. Non-progressive neurological disorder of movement and posture. Caused by damage to developing brain. Affects the motor system, coordination and muscle tone. Motor function, coordination and muscle tone, leading to lifelong disability. Non-progressive type, neurology, movement and posture affected, caused by damage to developing brain, affects the motor system, coordination and muscle tone, leading to lifelong disability. What's the etiology? Prenatal, perinatal, postnatal. Prenatal, in the womb. Intrauterine, in the womb, infections, torch infections, toxoplasmosis, rubella, cytomegalo, herpes. Maternal factors, preeclampsia, RH incompatibility, diabetes and other obstetric disorders. So intrauterine, maternal, congenital brain malformation, lissencephaly, holoprosencephaly. Lissencephaly, let's see what that is. So lissencephaly, okay. Smooth brain disorder. Holoprosencephaly, where it's not, it's open. Is that the one? No division of forebrain. Genetic mutations affecting brain development. Then there is perinatal, immediately before and after birth. So birth asphyxia, hypoxic ischemic encephalopathy, then there's prematurity and low birth weight, intraventricular hemorrhage and periventricular leukomalacia. Then there is neonatal stroke, birth asphyxia, prematurity and low birth weight, and neonatal stroke. And this condition can lead to intraventricular hemorrhage and periventricular leukomalacia. See, periventricular leukomalacia, what that is? Premature infants. Fluid PVL is an injury to white matter around the fluid filled ventricles. White matter. Okay, this one. Periventricular leukomalacia and neonatal stroke. Then there is postnatal, after birth, meningitis, encephalitis, traumatic brain injury, severe neonatal jaundice, that is kernicterus, which we have already learnt. I have seen the different classes depending on the causes and all that. Coming to classification of cerebral palsy, based on the motor deficit, based on the functional capacity. So, based on the motor deficit, we have spastic, extrapyramidal, ataxic and mixed. Spastic, extrapyramidal, ataxic and mixed. So, spastic, quadriplegia, all four limbs are involved, generalized spasticity, mental retardation and seizures. All four limbs, that is in quadriplegia, spasticity as the name suggests, mental retardation and seizures. Diplegia, spasticity mainly in the lower limbs, minimal upper limb involvement, so lower limbs. Diplegia. Hemiplegia, one side of the body, just like stroke, we have different names for different kinds. Similarly over here, monoplegia or triplegia are the rare forms. Extrapyramidal, where there is basal ganglia involvement, chorioathetosis, where there is involuntary movement, and dystonia, fluctuating muscle tone. So it can be more or less depending on depending on when you are looking at it. Then there is ataxic cerebellar, where we have atonic, poor balance and lack of coordination, and congenital cerebellar. Then finally there is mixed combination, spastic, extrapyramidal, basal ganglia involvement, and ataxic, and finally mixed. Based on functionality, functional capacity, let's see what the scale is. GMFCS, gross motor function classification system, and this is especially for CP. So level 1, level 2, level 3, level 4 and level 5. So level 5. So non significant limitation of activity, you can see here he is walking nicely. Level 2, mild limitation of activity, so he has a hard time climbing, so he is using this railing. Next, coming to class 3, moderate difficulty in mobility, now he is using wheelchair and I am not sure what this is called. And then class 4 is severe limitation, needs assistance, so somebody is helping him and he is using this robotic wheelchair. Next, coming to completely dependent on caregivers, so here he needs help. So these are the functional this is the functional one, this is the motor one. Functional one, we have seen the images. Next, coming to clinical features, the motor systems, speech and cognitive issues, seizures, feeding difficulties, visual defects, hearing impairment. So coming back to the definition, movement and posture disorder, disorder of movement and posture due to damage to developing brain, primarily affecting motor function, coordination and muscle tone. So let's come back. Motor system, these are the predominant ones. Speech, because other parts are also affected, then other, maybe these are the associated. This one could be possibly due to motor itself, and this one associated, this one possibly associated. So motor system, Motor symptoms: poor coordination, abnormal posture, spasticity. So depending on which class it is, there could be different types, variants of clinical features. Then there is delayed motor milestones, unable to sit and walk by expected age, persistent primitive reflexes, Morose, ATNR, grasp reflex. ATNR reflex is asymmetrical tonic neck asymmetrical tonic neck reflex, extension of arm and leg on the face side, flexion of arm on the skull side, promotes hand-eye coordination. So this is ATNR. Coming back, there is Morose reflex, grasp reflex and ATNR. Then speech and cognitive delays issues, delayed speech and intellectual disability. There could be behavioral problems like ADHD and autism. Next, coming to seizures, it is common in CP cases, 30 to 50%. Feeding difficulty, pseudobulbar palsy, leading to frequent aspirations. Visual defects like strabismus. This is a motor one. Yeah, this is the motor one. And retinopathy, this is an associated one. Hearing impairment, sensorineural deafness. So coming back, motor symptoms, a variety of them, and then we also talk about milestones and primitive reflexes. Speech and cognitive issues, we talk about delayed speech and intellectual disability and other problems. Seizures, we say that it is an associated one. And feeding difficulty, pseudobulbar palsy leading to frequent aspiration. Then there are visual defects like strabismus, retinopathy and hearing impairment. Coming to complications, musculoskeletal deformities, there is scoliosis, joint contraction, hip dislocation. Scoliosis, S-shaped spine, joint contractures, so contractures of the joint, and hip dislocation. Nutritional problems, difficulty swallowing, malnutrition, failure to thrive, probably because these are the secondary because of motor issues. GI symptoms, constipation, GERD, probably even that is associated with the motor difficulty with the eating and all that. Let's see if this is something extra. Does CP affect smooth muscles of GIT? Yes, it does. So neuromuscular control, so even that is affected, and that could be the possibly reason for these things. And there is this urinary incontinence, because even this one is gone affected. Yeah, look at it, esophageal dysmotility, gastric emptying and intestinal dysmotility and rectal dysfunction. Then coming to diagnosis, so investigations and how do you diagnose it. Clinical examination, history of perinatal visit, developmental delay and neurological deficits. Perinatal insults, not visits. Visits is for OBG. Perinatal insults, that is we have seen it already, all the injuries, infections and all that. Developmental delay and neurological deficits. So all these, history of these is important. Then assessing primitive reflexes. So all these reflexes, if there is persistence of these, that means something is wrong. Neurological imaging, we have MRI and CT. Preferred modality for detecting brain lesions like periventricular leukomalacia, we have already seen what that is. White matter tracts around the ventricles. And cortical malformations, anencephaly, holoprosencephaly and lissencephaly. And then there is CT scan for structural abnormalities or calcification. This is seen in toxoplasmosis, congenital infections. Then there is functional and developmental assessment. So ophthalmic and hearing evaluation, speech and language assessment, psychological and educational testing. So ophthalmic, eyes and ears, speech and language, psychological and educational testing. Then there is EEG if seizures are suspected. So all these things are also important. Next, coming to treatment. So it is a multidisciplinary approach, as we all know. So many aspects of life are affected. So number one, we need physiotherapy. So active exercises to relax spastic muscles, rhythmic muscle contractions to improve motor control, and assistive devices like bracers and walkers for mobility. Then there is medications, muscle relaxants, anticonvulsants, and botulinum toxin injections. Muscle relaxants, what are the names? Baclofen, dantrolene for spasticity, and there are benzodiazepines which act centrally for dystonia and arthritosis. So one is for spasticity, one is for dystonia and arthritosis. Then there are anticonvulsants because seizures are an associated feature. What do we use? Valproate, carbamazepine, levetiracetam. And botulinum toxin injections reduces spasticity in targeted muscles, and combined with stretching and splinting. Then we have surgical interventions, orthopedic treatments, tendo-Achilles lengthening to correct the foot deformity. So it is spastic case, right? So depending on that, their foot might be deformed. Adductor tenotomy, reduce hip dislocation risk. Adductor tenotomy, so adductors of the hip. Then posterior rhizotomy for spastic diplegia. Let's see what this is. Posterior rhizotomy, where it's the dorsal rhizotomy. Okay, this is this one, the spinal cord. Before surgery, what was there? Motor sensory muscle, and there was stiffness and flexibility. Oh yes, surgically reduced input from sensory nerve fibers. Dorsal root sensory. Okay, then spasticity reduces. Okay, is that this thing? Yeah, for spasticity. So sensory input reduces. I think it is related to that one of this one. There was a pathway in the spine which increased or decreased this one. What was it? The tone. I think it's related to that. Speech and occupational therapy, improving swallowing and communication skills. So the way they talk. Parental education and support, counseling on daily care, mobility, feeding and therapy compliance, psychosocial support for caregivers. Then finally prognosis, lifelong condition. So make sure that parental education is the important one. Better prognosis in diplegic and hemiplegic CP. Severe quadriplegic CP has poor prognosis, and early intervention significantly improves mobility and communication. So repeating the treatment: physiotherapy, medications, muscle relaxants, anticonvulsant, botulinum toxin, surgical interventions like tendo-Achilles lengthening, adductor tenotomy, posterior rhizotomy, and then speech and occupational, and finally parental education. So with this we end the discussion on cerebral palsy. Next, coming to meningitis. First one is pyogenic, that is bacterial meningitis. So here we learn everything about it. So it doesn't look big, but you need to expand more on this, like when you are writing. Pyogenic bacterial meningitis is an acute bacterial infection caused by inflammation of meninges. So meninges different from encephalitis. Encephalitis is the brain parenchyma, leading to high morbidity and mortality. It is more common in neonates and infants due to immature immune systems. Neonates and infants, it's more common. And then etiology and risk factors. Common bacterial causes and other risk factors. So bacterial causes includes, there are different based on the age bracket. First there are neonates, then there are 3 months to 3 year bracket, and beyond 3 years. So neonates: E. coli, pneumococcus, salmonella, pseudomonas, staph aureus. Yeah, E. coli, pneumococcus repeats itself till here, salmonella over here, just here, E. coli just here, and number 1 pseudomonas, number 1 only here, and staph aureus. Then 3 months to 3 years enters the Haemophilus influenzae and meningococcus. 3 months to 3 years. Then beyond 3 years, we just have pneumococcus as number 1, meningococcus as number 2. So again, E. coli, pneumococcus and some extras, Salmonella, Pseudomonas, Staph aureus. 3 months to 3 years, Haemophilus influenzae number 1 and pneumococcus, meningococcus. These come here. Then comes after 3 years, pneumococcus, meningococcus, and this repeat over a long age bracket, large age bracket, sorry. Then other risk factors: immunosuppression, fungal listeria, mycoplasma infections. So as we all know, these don't attack unless the immune system is suppressed. Recurrent meningitis, pilonidal sinus, CSF rhinorrhea, skull base infections. So pilonidal sinus, let's see how it causes meningitis. Possibly because it is sacrococcygeal region. It can go deep. Yeah, it is because of the deeper infection. So pilonidal sinus, it is a surgery topic. I was wondering, like, since it is just the hair and that particular small space in the skin, why meningitis? Then okay, if it goes deep, in that case we can see recurrent meningitis, CSF rhinorrhea, CSF leaking from here, from the nose, and skull base fractures. Skull base meaning the base of the skull, sphenoid and all that. Then contiguous spread, infected paranasal sinuses, all those maxillary, frontal, sphenoid and all those, mastoiditis, mastoid cells, and osteomyelitis. So contiguous spread from these infected these spaces. Then head trauma can allow bacteria to enter CSF. So head trauma. Pathogenesis, bacterial invasion occurs via hematogenous route, direct extension from nearby structures. So what are the nearby structures? Sinus and middle ear. So sinusitis and otitis media, infection over there can reach the brain. Neurological procedures or trauma, in that particular conditions too, there is easy access for the bacteria to reach the brain. Then bacterial replication in CSF causes intense inflammatory response leading to leptomeninges infiltration with inflammatory cells. So this is the basic pathology: brain edema, exudates, microglial proliferation. Microglia, as you all know, these are the reticuloendothelial aspect of the brain, of the central nervous system. And now this is the inflammation. This is activated cerebral vessel thrombophlebitis, inflammation of that, infarction, and hydrocephalus, meaning lots of fluid over there. Hydrocephalus, big huge head. Why is that? Because mainly because of inflammation and all that. And why there is inflammation? Because of either hematogenous spread or easy access, nearby access. Coming to clinical features. General symptoms, and there are signs and special presentation in neonates and young infants. So these you can't actually tell what it is, presentation neonate infant, but first you can tell it is meningitis. So general symptoms: acute onset febrile illness, lethargy, irritability, headache, seizures, altered sensorium progressing to coma, projectile vomiting, photophobia, and myalgia. This is what the patients complains with. Acute onset febrile illness, so fever is there, which was acute in onset. Lethargy, irritability, headache. Okay, this one is non-specific. Seizures, altered sensorium progressing to coma. So with this we know it is something dangerous. And then projectile vomiting, photophobia, and vomiting. So for projectile vomiting, this is a key finding. And then signs, we have neck stiffness, which is number 1 for meningitis. Brudzinski's and Koenig signs of meningeal irritation. Let's show it here. These are very important even for examination, so better to get this right. So Kernick sign, knee extension is painful. Kernick sign, patient supine with knee hip flex 90 degree, knee cannot be extended. Kernickus knee extension is painful. Then Brudzinski sign, neck flexion leads to knee flexion, NK. Brudzinski sign, neck rigidity, passive flexion of neck causes flexion of both the legs and thighs. Brudzinski sign, neck flexion leads to knee flexion and also the thigh flexion. So Kernick, knee extension is painful. Brudzinski, neck flexion leads to knee flexion and thigh flexion. Then there is papilledema, hypertension, so edema of the meninges, also edema of papillae in the eyes orbit, hypertension and bradycardia, and this is due to secondary to raised ICP, that is Cushing's reflex. So let us see what Cushing's reflex is. Cushing's triad, maybe that is the Cushing, not syndrome, triad. So Cushing's triad is the primary sign that often indicates increase in intracranial pressure, where there is increase in systolic BP, pulse and respiration. Let us see what the mechanism is. Better to know the mechanism because it is very interesting. So head injury, in this particular case inflammation, increased ICP, pressure on cerebral arteries, cerebral blood flow decreases, okay, and this affects the VMC. What does it do? VMC goes and touches upon the stagnant hypoxia, and because of the overall there is sympathetic, so cerebral blood flow decreases and brain is telling the other part of the brain that I need more blood. So this brain, what it does, it causes sympathetic outflow to increase. So what does it do? Sympathetic outflow, overall it causes increase in blood pressure. So because of that the brain now thinks that okay, at least now I will get more blood. So but still this pathology is still there, so it is not getting enough blood, but that is fine, that is different. But we need to know why there is decrease in heart rate, because high blood pressure secondary to this particular part leads to baroreceptor reflex, wherein the baroreceptors detect there is lot of blood pressure and then they try to reduce the heart rate. So overall that is the triad that we are talking about, which is respiratory suppression, bradycardia and hypotension. So respiratory suppression, why? Decreased blood flow to the brain, decreased oxygen to the brain, decreased pH and increased PO2. Widened blood pressure, irregular respiration. So overall respiration is affected. Next, coming to, where were we? Cushing's, yeah. Hypertonia, neck rigidity, yes, hypertonia and neck rigidity. Then petechiae maculopapular, so meningococcal meningitis, there is something called as Watterson-Fredrickson syndrome, where there is adrenal necrosis because of lack of blood supply, and because of this there is a lot of DIC like issues. And then this hemiparesis and focal cranial nerve palsies. So stroke like features, not completely, meaning a partly, hemiparesis, weakness of one side, and focal cranial nerve palsy, so some cranial nerves might be affected. TK cerebelli, flushing with abdominal skin scratch, flushing with, let's see how this looks like. Flushing with scratching. Presentation in neonates and young infants, irritability, refusing to bleed, vomiting, lethargy, drowsiness, fever or hypothermia, vacant stare, posturing, clonic seizures, shock and circulatory collapse. Irritability, refusing to feed, like generally seen in so many conditions, rehydration, other diseases, diarrhea and all that. Lethargy, drowsiness, same thing, repeated so many places. This one also non-specific feature in sepsis. Vacant stare, posturing, clonic seizures. So seizures, yes, vacant stare, absent seizures, possibly posturing may be affected, and shock and circulatory collapse possibly because of this one. What is it? The septic issues, either directly the sepsis part or secondary to this meningococcal thing, because sepsis by itself can lead to meningitis. Coming to complication, neurological, subdural effusions, hearing loss and long term effects. So, neurological complications, seizures, raised ICP, stroke, cranial palsy. So, we have seen this. Then there is SIADH, ADH secreted by syndrome of inappropriate ADH. Then there is hydrocephalus herniation. We need to why this is the cause. Why this in meningitis? Due to inflammation, increase in ICP and fluid imbalance. Here's this thing. Inflammation meninges hypothalamus to excess. Okay, hypothalamus is the one that is secreting it inappropriately. This leads to water retention and dilution of blood. Hyponatremia causes seizures. Okay, fine. Hydrocephalus, arachidonic villi, arachnoid villi, defective absorption of CSF. This leads to hydrocephalus. Cerebral herniation, this is fine actually because of the pushing of this thing. Okay, yeah, that's what we are. This is fine because of pushing, increased pressure inside the intracranial space. Coming to subdural effusions, Haemophilus influenza and pneumococcus. Subdural effusions seen in these particular conditions. So let's see what these are. Subdural effusions meaning below dura effusion, abnormal collection of CSF exudative between dura and arachnoid. Usually it's below the arachnoid, subarachnoid, but between that, okay, between those two things, subdural space. Hearing loss, sensorineural meningitis. So the hearing, the nerve pathway is very much close to the brain, so even that can get affected. Long term neurological deficits include these things like hemiplegia, epilepsy, intellectual disability. Next, coming to the investigations, lumbar puncture being number 1. So parameter, bacterial meningitis, appearance, it is turbid, WBC count more than 1K, neutrophilic predominance, obviously because this is bacterial. Proteins elevated greater than 100 milligrams per deciliter. Glucose, it's slow, less than 2/3 of serum glucose. CSF culture positive for causative bacteria. Then there is other laboratory. Then there are other laboratory tests, blood culture, CBC to identify bacteremia, serum electrolytes to check for SIADH and dehydration. CT MRI indicated if ICP high with focal neurological deficits. So all these things, and you can do more too. You can list it out based on all these things in case there is anything else that you can think of. Then coming to the treatment. So management, empirical antibiotic therapy based on age and causative organism. There are different for neonates, different for infants and older children. Neonates, there is ampicillin aminoglycoside, 300 milligram kg per day every 6 hours. Aminoglycoside, that is gentamicin. So ampicillin 300 milligrams per kg per day, 6th hourly. Then cefotaxime, 150 to 200, half of this, 20 milligram per kg per day, 8th hourly. Ceftriaxone, is it 8th hourly? Looks like that sometimes. Better to check. Is it 6th hourly? Every 6th hourly, divided into 4 equal doses. So this one divided into 4 equal doses. Divided by 4 equals 75. Okay, but this is 8th hourly, meaning 3 doses. Is it 3 doses? If Q8 maybe it's 3 divided doses. Yes, then it is 3 divided doses. So cefotaxime 3 divided doses, which is 150 to 200, or ceftriaxone 100 to 150. So we have decreased this by 50, 100 to 150, 12th hourly, that is 2 divided doses. So ampicillin, gentamicin, cefotaxime, ceftriaxone. This is 300, 4 divided doses, 150 to 200, 3 divided doses, 100 to 150, 2 divided doses. Then there is infants and older children. There is meningococcal, pneumococcal, Haemophilus influenzae, staph meningitis. So penicillin 400k to 500k units per kg per day, 4th hourly. So this is a lot more divisions, I feel, because this was 3rd rate, then this should be 6th. Well, the child eats so much, takes so much, and Q4 should be to 6 divided doses. That is a lot. 6 divided doses for meningococcal. So penicillin 4 lakh to 5 lakh and 6 divided doses, Q4H. Haemophilus influenza, cefotaxime, ceftriaxone, staph meningitis, vancomycin. If methicillin sensitivity, then nafcillin. Supportive management, dexamethasone, osmotic diuresis, anticonvulsants, and fluid management, fluid electrolyte management. Dexamethasone is to reduce the inflammation and hearing loss, 0.15 milligram per kg IV every 6th hourly for 2 to 4 days, 0.15. Then osmotic diuresis, mannitol 5 ml per kg over 10 minutes for each ICP. Anticonvulsant for seizure control, correct fluid and electrolyte imbalance. So that one is fine. So this one was supportive, that one was antibiotics. Next one is specific therapy for meningococcal meningitis. So epidemics caused by staph serotype A and C, pathogen petechial rash. Complication is this Waterhouse-Friderichsen syndrome, adrenal hemorrhage leading to shock, hypotension and coma. Shock, hypotension, coma. And this is for meningococcal meningitis. Meningococcal, this one penicillin 400 to 500k. Prevention, vaccination, pneumococcal, meningococcal, antenatal care, ensuring birth asphyxia, jaundice and sepsis are treated promptly or prevented in the first place. Early treatment of infections to prevent complications. We have 2 more minutes. We can go on to tubercular meningitis and check out what the overview is. We look at this. Yes, this is fine. Next, coming to overview, what it entails. It is a serious form of extrapulmonary TB that affects the meninges. Children between 6 months and 2 years. So 6 months and 2 years. It results from hematogenous spread of the bacteria leading to chronic inflammation and neurological complications. Chronic inflammation and neurological complication. What is the etiology? Causative organism is MTB, Mycobacterium TB. It is an acid fast, we know this. Aerobic, we know this, it is in the lungs. Gram positive, it's this thing gram positive type, but acid fast nature is also there. And then primary focus, usually in the lungs, primarily primary TB or miliary secondary TB with hematogenous dissemination to the meninges. Risk factors 6 months to 2 years. Immunosuppression, HIV, malnutrition, we have seen. In this one, what is it? The MAN2 test. There are different risk groups. Higher risk group is for HIV, where greater than 5 millimeter of induration is also considered as positive. Exposure to active TB cases. There is delayed BCG vaccination. Pathogenesis. So hematogenous spread, we have seen it already, to meninges. Bacilli target end arteries, leading to submeningeal tubercular foci, rich foci. Let's see how it looks like in case an image is available. So this is a rich foci, which is end artery being affected. infected alveolar macrophages goes inside rich focus, subarachnoid, submeningeal tubercular foci, that is rich foci. Tubercular bacillar ruptures into subarachnoid space, triggering these things: perivascular exudation, perivascular means near the vessels, exudation meaning it's an inflammatory this fluid. Then there is caseation necrosis, which is seen also in the lungs. Gliosis and giant cell formation, which is also seen in lungs, but gliosis we need to make sure what it is. Gliosis is astrogliosis, fibrous proliferation of glial cells due to injury. So this is similar to what happens in the other parts of the body, where some kind of this thing injury can lead to fibrosis or this thing over there, but here in this particular case it's the brain. Basal meninges predominantly affected, causing inflammatory exudates, vasculitis, infarcts and hydrocephalus. Basal meninges predominantly affected, so basal meninges causing inflammatory exudate, vasculitis, infarcts and hydrocephalus. So overall we are done with pathogenesis, and right now let's take a break and come back to do the pathology and clinical features and management. So for now I'll be pausing this session, meaning I'll be starting the break session, and then mic off. Yes. Yeah, so pathology of tubercular meningitis. Meningeal inflammation with thick grayish exudate. So we'll see it in this one, pathology of TB meningitis. Okay, brain in case of tubercular meningitis. Yeah, this one. Let's look at this properly. Okay, fine. Now coming back, meningeal inflammation with thick grayish yellow exudate covering the brain. So we couldn't see that there. Basal meninges involved leading to cranial nerve palsy. So they are showing the basal aspect. So with that, okay, we can remember something. Obliterated subarachnoid space, arachnoid villi and CSF drainage impairment leading to hydrocephalus. Okay, this is also understandable because subarachnoid space, arachnoid villi and CSF, which was also the case previously in the bacterial meningitis section, where hydrocephalus was one of the complications and CSF drainage being impaired. Choroid plexus congestion and tuberculosis in choroid plexus. Tubercles in choroid plexus. Next, coming to stages and clinical features. TBM progresses through 3 stages: prodromal, meningitic, stage of complications. So prodromal stage, low grade fever, irritability, restlessness, non-specific, loss of appetite, disturbed sleep, vomiting. Okay, now we are going somewhere, disturbed sleep and vomiting, then headache, photophobia, mild behavioral changes. So this is looking somewhat like meningitis case, somewhat, but let's see what happens now. Meningitic stage. So now we have reached the meningitis stage, where is neck rigidity, Kernick sign positive, remittent or intermittent fever. So even fever has been is remittent and intermittent now. Disturbed breathing, drowsiness, lethargy, seizures, focal neurological deficits, monoparesis, hemiparesis, hydrocephalus development with papilledema. So first we had prodromal stage, which initially didn't resemble meningitis, but last part we were like, okay, this is going to meningitic stage. Then now we know this is 100% meningitis with all the features: neck rigidity, intermittent fevers, breathing, drowsiness, lethargy, seizures, focal neurological deficit and hydrocephalus. Now finally stage of complications. So what is this causing? Loss of consciousness, worsening of fever, dilated pupils, nystagmus, squint, ptosis, ophthalmoplegia, chain strokes or bited breathing, bradycardia, decerebrate posturing. We have seen this, what this looks like, extensor posture. If untreated, fatal within 1 month. So loss of consciousness, worsening fever, dilated pupils, nystagmus, squint. So eye issues, eyes, then chain strokes or bited breathing, bradycardia, decerebrate posturing, like heart and decerebrate posturing, extensor response. If untreated, fatal within 4 weeks. Then there are investigations. First one is CSF examination, which is gold standard. So tubercular meningitis, appearance clear or slightly cloudy fluid, opening pressure is elevated, cell count, there it was neutrophilic predominance, here it is, and 1K plus WBCs, here it is 100 to 400, half of that, and lymphocytic predominance, here proteins are increased, glucose is 2/3 of blood pressure, same thing, chloride is low, and bacteric PCR, like TB test positive, and cultural sensitivity confirms TB, LJ media, but it takes a lot of time for the culture to grow the bacteria. Other diagnostic test, Mantoux test, positive but does not confirm it. Chest X-ray to check pulmonary TB, CT and MRI, basal exudates, so it's the basal part, so exudates in the basal part of the brain. Hydrocephalus, we know this is a complication because it blocks the arachnoid villi. Infarcts, and then inflammatory granulomas, which is a key finding in tubercular meningitis. And culture of gastric aspirate and urine to detect TB. And differential diagnosis, purulent bacterial meningitis, encephalitis, brain abscess, brain tumor, chronic subdural hematoma, and this typhoid encephalopathy. This thing has been this is a, what is it, this topic has been dealt with in detail in surgery part 2. There in neurosurgery section I mentioned it. Now typhoid encephalopathy and enteric encephalopathy. Next, coming to treatment of TBM, tubercular meningitis. So ATT we know from the beginning. What is it? Intensive phase, continuation phase. Intensive phase for 2 months, continuation phase for 10 months. 10. This is here in this particular case. What are the drugs? Isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. So 5, 10, 15, 20, 30, 40, then reduced to 30 milligram per kg per day. And the first two we have maximum limit 300 and 600. Continuation phase we have isoniazid, rifampicin with or without ethambutol. So this is specifically for meningitis, which is 12-month minimum. Adjunctive therapy, dexamethasone to reduce the inflammation, which is IV first, 0.15 milligram per kg 6th hourly, meaning divided into 4 doses, whatever there is. Then taper to oral prednisolone. Then there is ventriculoperitoneal shunt for hydrocephalus. Ventriculoperitoneal means ventricles connected to peritoneum, and this drains the CSF. Then there is symptomatic treatment. We need to know how this looks like, but this, because this is looks like a lot complicated. You can imagine it looks like a very complicated thing. Yeah, it is actually a complicated. See how it connects the brain to this brain gut axis. No, that's a different thing, but sounds somewhat similar. Then there is symptomatic treatment with controlling of seizures, anticonvulsants with anticonvulsant with correction of dyselectrolytemia. Then finally the long term complications, neurological complications, hydrocephalus being most common, because as we all know, repeating again, with arachidoid villi being obstructed. Then cranial nerve palsies, because we have seen ophthalmoplegia, squint and all that. Papilledema is not this thing, but rest of it. Tuberculoma, myeloradiculopathy, we need to know what this is. Myeloradiculopathy. It's a complex condition that affects spinal cords and nerve. Myelopathy radical. Spinal nerve roots, radicals, spinal nerve roots and the spinal cord. Stroke, epilepsy and ocular palsies. So it is mentioned here. Other cranial nerves can get affected. And endocrine systemic complications, adrenal insufficiency seen even over here, hypothalamic dysfunction, iatrogenic hepatotoxicity, SIADH and all that, iatrogenic hepatotoxicity from antitubercular therapy. Which one is it? Isoniazid and rifampicin 2. Hearing loss and intellectual disability. And these are the in general, like except some things like this one and this one, most of things you can mention it even for normal bacterial meningitis. And this is anti-TB treatment, 12 months minimum with the drugs 5, 10, 15, 20, 30, 40 and 30 again with continuation phase for 10 months. Then dexamethasone 0.15 milligram per kg IV 6th hourly for 6 days. Then ventriculoperitoneal shunt for hydrocephalus and do the seizure correction and electrolyte correction. Then the rest of the things like normal TB and CSF analysis and the different stages of TB, meningitis, prodromal, meningitic and finally the stage of complications. And we have also seen the pathology, pathogenesis, etiology. Now coming to hydrocephalus, which is the last topic in this particular section. Hydrocephalus refers to enlargement of head due to accumulation of CSF in intracranial spaces. This occurs due to increased production or decreased clearance or obstructed flow. Etiopathogenesis. So CSF production and flow pathway. So this is a normal pathway what they are showing. We need to look at a diagram to understand the anatomy well. So here it is, yes. Very nice diagram. So lateral ventricle, these are in the sides of thalamus and all. Then these drain into third ventricle, then through cerebral aqueduct go into fourth ventricle. Then from fourth ventricle, there should have been a better diagram. This one I think, yeah, lateral ventricles, yes, through the intraventricular foramen into the third ventricle, then through the cerebral aqueduct. Where is it? Cerebral aqueduct, somewhere here. Yeah, cerebral aqueduct into the fourth ventricle, which is near the cerebellum. Then through the lateral and medium apertures, which are Monro and Magendie. Monro and Magendie, right? Luschka and Magendie. Monro is something else. Monro is for the first one. Foramen of Monro into the third ventricle. Monro, interventricle, Monro into the third ventricle, then Luschka and Magendie finally into subarachnoid space, then arachnoid villi of venous sinuses, then finally draining into the venous system. Jugular veins. Only 20% of the CSF enters the subarachnoid space, while the rest is reabsorbed by the arachnoid granulation into the dural venous sinuses. Next, coming to causes of hydrocephalus. So there are congenital and acquired causes. Congenital, torch infections, intrauterine infections, that's the right word. Rubella, CMV, toxoplasmosis. So not all. Rubella, CMV, toxoplasmosis. Intracranial bleeds, intraventricular hemorrhage, bleeds and hemorrhages, and malformations like aqueductal stenosis, which is blocking the pathway. So cerebral aqueduct we have seen, draining into the fourth ventricle. Dandy-Walker syndrome, Arnold-Chiari malformation. So all of these obstruction of the CSF pathway leading to hydrocephalus. Midline tumors obstructing CSF flow being affected. Then acquired causes, TB, chronic pyogenic meningitis, post intraventricular hemorrhage. Then posterior fossa tumors. Which are the posterior fossa tumors? Medulloblastoma, astrocytoma, and ependymoma. Then there is intracranial hemorrhage and ruptured aneurysm, which is similar to this, repeated here, but this is an acquired cause. And classification, non-obstructive and obstructive. So what does it mean? Communicating, non-communicating. So first let's see non-obstructive. CSF accumulate due to failure of absorption, but here obstruction within ventricular system prevents the outflow. So absorption is affected, here movement is affected, meaning path flow is affected, outflow. Causes over here includes failure of absorption, post hemorrhagic, meningitis, the inflammatory thing causing issues there, and choroid plexus papilloma, where there is excessive production and absorption is very slow, like compared to this. Then there is, for this one obstructive, there is aqueductal stenosis, congenital infections. So most of these, Arnold-Chiari malformation, Dandy-Walker, tumor abscesses and hematomas, most of these lie here except the last one, which can be here too, midline tumors, so can't really tell. So most of these obstructive type are congenital ones. Yes, coming to the next one, clinical features. Neonatal and infantile hydrocephalus, rapidly enlarging head signs, because that is the definition, bulging and tensing anterior because it is a child, and anterior frontal are usually there and they will bulge because of this. Widely separated cranial sutures, because same thing, this is anatomical landmark, even this one is. So all of these widely separated. Dilated scalp veins, thinning of cranial bones. Yeah, so let's see an image to make it look, to make for us image so that we can understand it better. Yeah, so yeah, this one here you can see the veins too, veins, large head, frontal sutures are separate, thinning of cranial bone, sunset, visible sclera above cornea, yeah, you can see. And then positive mace vein sign, cracked pot resonance on skull percussion, crackpot resonance. So this is a new type of resonance, different from dull note and resonant note. Then there is irritability, poor feeding, vomiting, which is also seen in other CNS cases, seizures and spasticity in advanced conditions. So this is also seen in CP. Hydrocephalus in older children and adults. Headache, nausea, projectile vomiting, ataxia, gait disturbances. Overall, this mimics somewhat like this one. What is it? Meningitis. And in fact, this is the sequelae of meningitis, right? There is seizures and papilledema, spasticity, urinary incontinence, cognitive decline, progressive mental deterioration. In general, the CNS, bad CNS complication, hydrocephalus. Then we have diagnosis, clinical features. Through that we can diagnose, or there are imaging studies. Clinical serial monitoring of head circumference 1 cm increase every 2 weeks. Persistent suppression of squamoparietal sutures. Let's see the squamoparietal sutures. Squamoparietal sutures. So this is the squamoparietal suture, increasing suppression of these on either sides. Signs of increased ICP, which are Cushing's triad. So Cushing triad forms the sign. Then there are imaging studies. Ultrasound neonatal screen detects ventricular dilation. CT or MRI brain identifies site of obstruction, detects ulnar Chiari or Dandy Walker malformation. So CT and MRI brain for proper classification. Then there is differential diagnosis, megalencephaly, large brain volume. Let's see this. Okay, something that is brain is abnormally large, big brain, chronic subdural hematoma. Treatment, medical treatment to reduce the intracranial pressure. So mannitol, acetazolamide, 50 mg per kg per day. Diuretics provides temporary relief. Oral glycerol helps reduce CSF pressure. So reduction of the volume to reduce the ICP. And surgical intervention, ventricular peritoneal shunt, diverts CSF into peritoneal cavity, complications, obstruction, infection, sepsis. So it is obvious looking at how distant this tongue is from this thing. Third, ventriculostomy. Endoscopy procedure preferred in obstructive endohydrocephalus reduces the need for permanent shunting. Third, ventriculostomy. So hole is made in the third ventricle. Let's see the image again. What is it? CSF. No, let's see third ventricle. So lateral ventricles, third ventricle, fourth ventricle. Hole is made in third. Why is it third? Because lateral form the 1 and 2. Shunt placement in TBM. Tubercular meningitis with progressive hydrocephalus require early shunting. So we have seen it already. Shunting for peritoneal shunting. Which one? What peritoneal? Ventricular peritoneal. Prognosis, high mortality rate without treatment. Even treated cases might have neurological sequelae. Common sequelae include motor deficits, cognitive impairment, vision problems, hearing loss, behavioral disorders. So we have seen the medical treatment, surgical treatment of hydrocephalus, the diagnosis, investigations for hydrocephalus, the signs, clinical features of hydrocephalus which mimic the meningitis, not 100%, here there is no fever and all that, but other things mimic. It can also mimic CP like features. And there is classification to non-obstructive, obstructive, where obstructive is mainly looks like a lot of congenital factors, causes are clubbed into this, but it can also include acquired like tumors. And we also saw the CSF production. So with this we end the hydrocephalus section. Next, coming to the next chapter, next unit 19. So with this we are done with most of the big chapters. I am so happy right now because this has been tiring. Yes, acute generalized flaccid paralysis. This looks, if you remember from community medicine, this looks somewhat similar to acute flaccid paralysis, which is caused by polio, which in fact is the leading cause of this particular problem, meaning most important cause. Might not be the leading cause right now because in most of the places in the world it has been eliminated and eradicated. It says, let me drink some water. It is a clinical syndrome characterized by rapid onset of weakness of paralysis of skeletal muscle due to lower motor neuron dysfunction. The paralysis is typically symmetric, affecting all four limbs, may involve respiratory and bulbar muscles. So, characterized by rapid onset of weakness and paralysis of skeletal muscles due to LMN dysfunction, typically symmetric. So, flaccid, right? Flaccid meaning LMN type. If it was spastic, it would have been UMN type, affecting all four limbs and may involve respiratory and bulbar muscles too. Etiology and causes, there are infectious causes, autoimmune causes and metabolic causes. Infectious causes, polio number 1, caused by poliovirus affecting AHC of spinal cord. GBS, post infectious autoimmune disorder causing demyelination of peripheral nerves. Campylobacter jejuni. Botulism, toxin mediate and neuromuscular disorder from the Clostridium botulinum. Diphtheria, neurotoxin affecting peripheral nerve. This is mainly not so well known. Rabies, yes, we know, can present as flaccid paralysis in paralytic rabies. Then arboviral encephalitis, West Nile and Japanese encephalitis. Yes, I have included vaccine information about this in this section, immunization section. Coming to autoimmune and neuromuscular, there is myasthenia gravis, where autoimmune destruction of and ACH receptors. Acute inflammatory demyelination, AIDP, polyneuropathy, AIDP, subtype of GBS leading to progressive weakness. So, what are we talking about? Autoimmune and neuromuscular. So, all are these autoimmune and neuromuscular. Transverse myelitis, inflammatory disorder affecting spinal cord leading to motor and sensory deficits. Coming to metabolic and toxic causes. Metabolic and toxic, hypokalemia number 1, OP poisoning number 2, heavy metal poisoning number 3. Metabolic and toxic. Metabolic, this one, toxic, these. Metabolic can cause reversible paralysis, this one, hypokalemic periodic paralysis. OP poisoning, irreversible inhibition of acetylcholinesterase causing neuromuscular dysfunction. So, there is a lot of acetylcholine and eventually it is like NMJ is like, I am done with this, too much of acetylcholine, I am not working anymore. Heavy metal poisoning, lead and arsenic poisoning causing neuropathy. So, coming to the pathophysiology of AGFP depends on the underlying cause. Peripheral nerve demyelination, Guillain-Barré syndrome, autoimmune attack on the myelin leading to slowed nerve conduction. Anticonvulsants in poliomyelitis, neural junction dysfunction where in myasthenia and botulism, impaired synaptic transmission, metabolic or toxic dysfunction, direct disruption of ion channels. So, based on this you just expand on how each of them work. So, most of them are very easy. This one ASCA being affected, this one autoimmune to the peripheral nerves of the peripheral nerve. This is also autoimmune, but make sure this is neuromuscular. In botulism we know neuromuscular blockade, and then rest of it should be fine actually. Like expand each upon each of these. Then there are clinical features. Symptoms, it's there in the name, Progressive weakness means from lower limbs ascends upwards like GBS, hypotonia, hyperreflexia, loss of muscle tone and absent deep tendon reflex like LM and lesion. Bulbar involvement, dysphagia, dysarthria and respiratory compromise in severe cases. Autonomic dysfunction seen in case of GBS, tachycardia, blood pressure fluctuations, and sensory involvement usually preserved in myasthenia gravis and botulism but affected in transverse myelitis and GBS. Red flags: respiratory muscle involvement may require ventilatory support. Sudden onset paralysis will rule out stroke. So, respiratory muscles, it's a big problem, so you need respiratory support. Sudden onset paralysis, you need to rule out stroke or toxic neurotoxics in inflammation. And it is a recent vaccination, infection or diarrhea suggesting GBS. Now, there are different investigations. First, we do clinical examination, assess power, reflexes, tone, because it is a lot of this thing, element type of this one lesion. Cranial nerve involvement for bulbar, cranial nerve assessment for bulbar involvement, sensory testing to differentiate from upper neuron, motor neuron lesion, as I mentioned earlier. So, differentiate it properly, sensory testing is important. Then lab investigations, EMG, nerve conduction studies, demyelinating versus axonal pathology, reduced nerve conduction velocity seen in case of GBS. CSF findings, elevated protein with normal WBC in GBS. There is something called as albuminocytologic dissociation, where there is a lot of proteins but lack of WBCs. Pleocytosis in viral or autoimmune diseases. Serological test we do for polio, West Nile, Japanese encephalitis for detection, and toxin assay for botulinum toxin. Then there are blood tests, electrolyte detection for hypokalemia, hypophosphatemia, antibodies for myasthenia gravis, anti-acetylcholinesterase, anti-AChR receptor and anti-musk antibodies. MRI spine helps rule out transverse myelitis, compressive myelopathy. Then the management. So, since the variety of causes and all of that, you need to look specifically to treat the cause, but in general, airway and breathing support, mechanical ventilation if respiratory failure occurs. Thrombophlebitis, patients with prolonged immobility require anticoagulation because of DVT and all that. Specific treatment, Guillain-Barré, IVIG and plasmapheresis. For polio, supportive and physical therapy because it is very difficult to cure it. Myasthenia gravis, acetylcholinesterase inhibitors, pyridostigmine, steroids and IVIG. IVIG why? Because autoimmune, it is very helpful. Botulism, there is antitoxin, supportive care, hypokalemic paralysis. Potassium, give potassium because it is reversible, organophosphate poisoning, atropine and pralidoxine. Prognosis, favorable outcome in GBS with early support. Myasthenia gravis is a chronic disorder. Poliomyelitis can lead to permanent in severe conditions. Complications include respiratory failure, pneumonia, autonomic instability and long term muscle weakness. So, with this we covered the management, the investigations like EMG, NCS, CSF analysis, PCR, blood test, MRI. We covered the clinical features mainly resembling LMN type, and we try to differentiate from the UMN type. And pathogenesis based, we expand it on the etiology that we have, and this we end the neuromuscular disorder section. How much time do we have? We have 20 minutes. We can finish ALL hopefully, because it's a 10 marker, I think. Yeah, it is a 10 marker. Yeah. So, ALL, acute lymphoblastic leukemia. So, pediatric age group, most common malignancy, it is blood malignancy is leukemia is ALL. It's a single originating from single B or T lymphocyte progenitor, most common childhood cancer, accounting for 25% of all pediatric malignancies. So it becomes very important for us as medical students. Pediatric age 2 to 3 years, commonly Caucasian males. Higher in chromosomal abnormalities. What are those? Down syndrome, Bloom syndrome. So Down syndrome, well known association. Bloom syndrome to Fanconi anemia, ataxia, telangiectasia. 4 disorders. Then classification. There is L1, L2, L3, and within L3 we have there are expression of different surface immunoglobulins. 85% are B cell, 15% are T cell, 1% is Burkitt, mature B cell. Then there is immunological classification defined by flow cytometry to determine cell lineage. So we need this to get the class right, and subclassified into pre-BAL, mature BAL, TALL, BALL, pre-BALL, mature BALL, TALL. Myeloid associated antigens 13 and 33. So these are myeloid associated 13 and 33, useful in monitoring minimal residual disease. Genetic classification, cytogenic and molecular. Based on genetic rearrangement, there is this genetic classification, risk assessment of childhood ALL, and common genetic risk factors include common genetic risk factors include T1221 BCR ABL fusion, hypoploidy, MLL translocation, trisomy of these 4, 10, 17. But before going in, we need to look at morphological L1, L2, L3 for L1, L2, L3 ALL. Acute lymphoblastic leukemia. You can see small uniform cell nuclei with condensed chromatin and conspicuous nuclei and scanty cytoplasm. Wait a second, I need a better. Yeah, it comes under FAB classification. So L1, I'll take a picture. Take a picture of this, because this one is better to know it. So it is Part-6. New document. Yeah, L1, L2, L3 morphological subtypes of ALL based on FAB classification. Breakdown: L1, L2, L3 small uniform cells with scant cytoplasm, regular nuclear shape and homogeneous chromatin, which looks normal. L2 larger, more heterogeneous nuclei with irregular nuclear shapes, variable chromatin and more cytoplasm. L3 distinguished by large homogeneous cells, large not heterogeneous, homogeneous with abundant deeply basophilic cytoplasm, prominent cytoplasmic vacuolation. And then within L3 we have different these are homogeneous type, right? Large homogeneous type with different cell surface expressions. And then based on we have also different genetic factors. Immunological classification based on flow cytometry and CD1333 being expressed, and genetic classification includes risk classification, risk stratification. It it is used for stratification and common genetic risk factors. Then coming to pathogenesis, post-conception somatic mutations in lymphoid cells, leukemia specific fusion gene sequences found in neonatal blood spots. So, somatic gene mutation keyword, leukemia specific fusion gene sequences. So, when you do the blood spots, fusion gene sequences are seen. Exposure to diagnostic radiation in early childhood, yes. So, with this there is increased risk association with BAL and Epstein-Barr viral infections. Epstein-Barr, well known for Burkitt's, EBV. Then pathogenesis, multiple genetic damages to lymphoid progenitor cells. So, genetic damage to progenitors, normally it is normal. If there is genetic damage, there is malignant transformation and proliferation, lack of cell maturation leading to resistance to apoptosis. Lymphocyte proliferation replaces normal bone marrow precursors. Lymphoblast proliferation replaces the normal ones, and then ineffective hematopoiesis and organ infiltration. And then common mutations include, like among these, this is a separate this thing, BCR-ABL, that is tyrosine kinase mutations, breakpoint cluster region, increased growth and survival in this particular case, and MLL translocation, differentiation, self-renewal defects. What are the clinical features? Non-specific in all kinds of, you can't actually tell ALL, AML, but still let us see general features. But BAL, there is something called as, there is night sweats and all that. B symptoms, fever, fatigue, malaise, irritability, anorexia. So, these are general symptoms. Bone pain, long bones, periosteal involvement, bone infarction. If there is organ infiltration, lymphadenopathy, hepatosplenomegaly, priapism. There is CNS involvement, cranial nerve palsy, increased ICP, hypothalamic syndrome, spinal cord compression. You usually don't think about all those things when we think about leukemia. Only thing we think about is these findings. But even the rest, bone involvement, bone pain, organ infiltration, CNS involvement, SVC syndrome, where mediastinal mass, compressing airways, this one, pressure symptoms become important, leukocytes, microcirculation, blockage by large deformed lymphoblasts, and even these also come into play. What is it? The bleeding tendencies, pallor mucosal membrane hemorrhage. There is petechia, purpura, gingival hypertrophy, testicular enlargement in infants with ALL. We need to know why this thing is. Why? Leukemia infiltration test, same thing. Papilledema, focal neurological deficits. Then there are investigations. Peripheral blood smear, profound neutropenia, hyperleukocytosis, thrombocytopenia. Neutropenia, hyperleukocytosis, thrombocytopenia, circulating lymphoblasts. So, with this, can you tell whether it's actually immune strengthening or immunosuppressive state? It's actually an immunosuppressive state where it is not able to fight the infections. Tumor lysis syndrome, elevated uric acid. So, whenever the cells die, they lead to release of these uric acid, hyperkalemia, potassium, phosphate, and calcium, and hypocalcemia. Not that these. And whenever the tumor dies, these things are released. Also, these things, LDH and liver enzymes are elevated, and creatinine due to leukemic infiltration of different organs. We need to know why hypocalcemia occurs in tumor lysis syndrome. It happens in massive tumor breakdown leading to this one. Okay, the increased phosphate which is released by the cells, they bind to calcium, leading to hypocalcemia. Increased creatinine, better to check this one also. Why this? Into the kidneys. Okay, fine. This one into the kidneys. Bone marrow aspirate and CSF analysis. Lymphoblasts in marrow, abnormal WBC in CSF. So treatment, we have chemotherapy protocols and supportive care. How much time there is? Okay, we have enough time. So intensive chemotherapy followed by maintenance therapy. So chemotherapy protocols, we have different phases: induction phase, consolidation phase, interim maintenance, delayed intensification and maintenance again. So induction lasting for 1 month, 4 weeks. Consolidation lasting for 1 to 2 months, 4 to 8 weeks. Next one lasting for 2 months, 2 months, and last one lasting for 2.5 for girls, 3 years for boys. So let's see what the first one, induction phase, comprised of. First one is vincristine and asparaginase, daunorubicin, methotrexate, prednisolone, dexamethasone. These are for anti-inflammatory section, like and these vincristine, asparaginase, daunorubicin, methotrexate. This is what we need to remember. Consolidation, methotrexate, again cyclophosphamide, cytosine, arabinoside 6-MP, 6 mercaptopurine, 6 Tg. What is 6 Tg? Tioguanine. 6 Tg is tioguanine. More intensive chemotherapy for intensive maintenance, interim maintenance, methotrexate, cyclophosphamide, 6 Tg, cytosine, arabinoside, prednisolone. That is delayed intensification. That is for 2 months. Maintenance, oral methotrexate 6-MP. That is for maintenance. Wait a second, let me try to copy this and try to make a mnemonic from this particular thing. Let's make it the mnemonic. Make it easier to remember. I can improve defense maintenance. So first one we can do this one. I can improve defense and maintain. This is for PEDS 6. PEDS. I'll close this. This is PEDS 6. And this is the next page. I can improve defense and maintain. I for induction, C for consolidation, I for interim maintenance, D for delayed intensification, M for maintenance. Next, coming to specific. VIP DM, VIP doctor, dexamethasone, prednisolone. VIP, not VIP, VLP, prednisolone, daunorubicin, methotrexate. MCC, like MC squared, but with 6's, MC squared with 6's. Let's copy this first. Looks good. Both are good. Next, coming down. Okay, VIP DM, vincristine, asparaginase, prednisolone, DM, daunorubicin, methotrexate. And consolidation, MCC 6, MC squared, methotrexate, cyclophosphamide, cytarabine 6 mercaptopurine, 6 tioguanine. Interim management 6-8 weeks. More intensive, more chemo coming. More intensive. Wait a second. More intensive chemotherapy for 8 weeks. and maintenance, sorry, this one MCC 6p by consult, but add prednisolone. 6 gone, 6 MP is gone, 6 TG is still there. So that is 6 MCC 6p. And maintenance MNM, methotrexate 6 mercaptopurine. Okay, this one is fine, good. We can remember this entire sheet with that. And that's what I think. The title makes sense. Pediatrics made easy, but it is not so much in depth, or not good amount of, not an amazing instructor. Yeah, coming to supportive care, complications management, infections are the main one. So for that we do broad spectrum antibiotics, antifungal therapy, pneumocystis prophylaxis. Because CD4, if it drops, it is very painful. Bleeding, platelet transfusion, coagulation, because we have seen even this one is a issue, is a problem. Then anemia, hemoglobin less than 8, platelet rich, this thing, RBC perfusion, packed RBC, yes. Hyperleukocytosis, hydration, platelet transfusion, exchange transfusion. Tumor lysis syndrome maintains urine output, allopurinol or rasburicase. For every complication we have the treatment here. 3 more minutes, we can go to the next one too. CNS prophylaxis, intrathecal methotrexate, cytosine arabinoside, hydrocortisone, cranial irradiation in high risk cases to prevent CNS relapse. Prognosis, long term survival approaches 90%. Risk factors include ionizing radiation exposure, chemotherapeutic agent resistance, organic solvent exposure, chromosomal abnormalities. So if you want to know if the prognosis is bad, these are the specific conditions that can worsen the prognosis: resistance, radiation, exposure to organic solvents, PNH, chromosomal abnormalities. So with this we end the section on ALL. Next, coming to the next section, let's see. Yeah, actually we will just do the initial part, then we'll take a break. Juvenile idiopathic arthritis, JIA for short, previously known as JRA, R for rheumatoid. Chronic idiopathic inflammatory disease, which is chronic, one or more joints in children below 16 years with symptoms persisting for at least 6 weeks. JIA characterized by chronic inflammation in joints, often with systemic manifestations. Clinical features, general symptoms, insidious or acute onset with variable severity. Symmetric involvement of both small and large joints. So small joints like IP, PIP, DIP, and then also wrists, temporomandibular, ankles, knees, hip and cervical spine. This one, ankle, knees, hips, cervical. So any of these. Swelling, warmth and tenderness of affected joint, so similar to rheumatoid arthritis, but this is in kids. Limited joint mobility due to inflammation and contractures may develop. Morning stiffness lasting for greater than 1 hour. Now systemic symptoms. Now there is called as Still's disease, which stands for systemic JIA. Prolonged remittent fever, transient maculopapular rash over trunk and limbs. So one was fever, other one was rash over trunk and limbs. We'll just finish this off. we'll see. Yeah, myalgia, weight loss, hepatosplenomegaly, lymphadenopathy, myalgia, muscle pain, weight loss, hepatosplenomegaly, lymphadenopathy, eye issues, uveitis, pericarditis, heart issues, myocarditis, heart issues, pneumonia, lung issues, pleurisy, lung issues. So it forms the systemic symptoms. So make this one: fever, rash, muscle pain, weight loss, large enlarged liver, spleen, enlarged lymph nodes, eye issues, heart issues, lung issues. Next, coming to eye involvement, chronic uveitis in oligoarthritis subtype, iridocyclitis, keratoconjunctivitis. Next, coming to extra articular features, subcutaneous nodules, growth retardation, deformities and osteoporosis. Subcutaneous nodules, growth retardation, deformities and osteoporosis in chronic conditions. Special clinical signs: salmon colored extravascent rash. We need to look it up. Like 5 more points, then we'll take a break. Yes, salmon colored rash, you can see it really clearly. Dactylitis, sausage like swelling of psoriatic digits in psoriatic arthritis. Dactylitis, yes, dactylitis. Then there is enthesitis, tenderness at ligament, joint insertions, anemia of chronic disease, which is seen in almost all the chronic inflammatory conditions. So salmon colored evanescent rash, dactylitis, enthesitis, anemia of chronic disease. This is in addition to extraarticular manifestations like subcutaneous nodules, growth retardation, deformities, osteoporosis, uveitis, iridocyclitis, keratoconjunctivitis, systemic signs where different organs are affected, and that is fever and rash, and general symptoms of this specific disease as the name indicates, like that is idiopathic arthritis, right? So arthritis, so joint involvement, different joints that are involved, contractures may develop, morning session greater than 1 hour. So with this we take a break. Yes. So let's continue with where we stopped. Yeah. So investigations in juvenile idiopathic arthritis. It is a clinical diagnosis, but lab and imaging helps to rule out different things, different diseases. So laboratory investigations: CBC, anemia of chronic disease, and polymorphonuclear leukocytosis, and thrombocytosis. So both are increased. Neutrophils as well as platelets. ESR CRP, mild elevation in inflammatory types. Rheumatic factor positive in polyarthritis, RS positive type, and ANA antibody associated with uveitis common in oligoarthritis. HLA-B27 enthesitis related. So depending upon what it is associated with, a lot more, depending upon that there are different this one involved. If it is more of polyarthritis type, it is rheumatoid, there is rheumatoid factor. If it is uveitis, it is ANA and HLA-B27 in case of enthesitis. And then imaging studies: plain X-ray, ultrasonogram for soft tissue swelling, periarticular osteoporosis and joint effusions, and later erosion of articular cartilage, joint space narrowing. An MRI detects early synovitis, joint inflammation. Echo if pericarditis is suspected. Synovial fluid analysis rule out septic arthritis, shows inflammatory changes, WBCs and polymorphonuclear cells. What are the treatment measures? So we have seen investigations, different this thing that could be done, imaging, different things that could be done, synovial, septic arthritis and inflammatory changes. For septic arthritis, to rule out this, you do so in this particular case we know that there is a lot of WBCs. Treatment: GI has no cure. Management aims to suppress active disease, preserve joint function and reduce pain and prevent long term complications. So what are the goals? Suppress active disease, preserve joint function, reduce pain and prevent long term deformities. General measures, and there are medical therapies that are available. So encourage joint mobilization, minimal exercise at least twice daily even in acute phase. Heat therapy, hydrotherapy for pain relief. Heat therapy, hydrotherapy for pain relief. Emotional support and counseling for chronic illness. So these are the things. And then medical therapy, DMARD, just like we have it for rheumatoid arthritis, disease modifying anti-rheumatoid drugs, first line treatment to prevent joint damage. Methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. NSAIDs, first line symptomatic therapy, naproxen, ibuprofen, indomethacin. So specifically for enthesitis related, enthesitis meaning joint tendon insertion sites over there. Naproxen, ibuprofen, indomethacin. Corticosteroids used in severe GIA, pericarditis, myocarditis, uveitis. Intra-articular steroid joint injections for oligoarthritis. Then biological agents, there are different types: anakinra, IL-1 receptor antagonist, canakinumab, anakinra, IL-1, canakinumab, monoclonal antibody to IL-1 for IL-1, tocilizumab, monoclonal antibody to IL-6, interleukin 6, infliximab, golimumab, adalimumab, TNF alpha inhibitor, etanercept, recombinant soluble TNF alpha inhibitor, abatacept, T cell activation inhibitor, azathioprine, cyclophosphamide, cyclosporin, IVIG. So, and surgically we have, so before that let's revise this. DMARDs, we know the DMARDs, methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. NSAIDs, first line symptomatic therapy, which includes naproxen, ibuprofen, indomethacin, corticosteroids, intraarticular joint injections, and then biological agents, canakinumab, tocilizumab, infliximab, golimumab, adalimumab, etanercept, abatacept, and other immunosuppressive agents, azathioprine, cyclophosphamide, cyclosporin, IVIG. And then there is surgical therapy, joint replacement therapy, and tendon release procedures. And complications, uveitis we have already seen, growth retardation, joint contractures and deformities. Macrophage activation syndrome is life threatening. Let's see what this is once, because I can't exactly remember. It's like a septic kind of a sepsis kind of thing. Features into high grade hepatitis, lymph, yeah, something like sepsis, but macrophages are involved. Anemia, secondary amyloidosis, subcapsular cataracts, and these are the things that show the prognosis. And with that we end the section on JIA. Next, coming to Down syndrome. Down syndrome is the major genetic disorder that we need to know, and let's go in detail. Probably it is the 5-marker written in terms of as if it's a 5-marker. So Down syndrome is the most common chromosomal disorder, 1 in 1000 live births, where there is an extra copy of 21. That's why it's called trisomy. Non-disjunction, translocation, or mosaicism. Advanced maternal age significantly increases the risk. So chromosomal abnormalities, there is trisomy 21, extra copy of 21 due to maternal non-disjunction in meiosis 1. Translocations, chromosome 21 translocated onto 13, 14, 15. And there is mosaicism, wherein only some have trisomy 21, others have normal karyotype. So we have 3 different ways of three different mechanisms. One is trisomy itself, extra copy of 21, because of non-disjunction meiosis 1. Translocation, chromosome 21 translocated onto 13, 14, 15, and then mosaicism. Coming to clinical features. So before that, let's look at a picture of a person with Down syndrome. Syndrome child. Now here it is. So can we read anything? Yeah, typical faces with apicanthal folds. So apicanthal folds you can see, slanted upward palpebral fissures, brush-filled spots on iris, small broad hands with simian crease. So you can see single palmar crease and clinodactyly of 5th digits, small 5th digit. Then wide gap between first and second toes, small hypoplastic ears, and then you can see fissured tongue. Yeah, so flat. Let's see again another child. This is for general public, pediatrics. Yeah. Small a flat nasal bridge. This is how it looks like, flat nasal bridge. Can you see it? Flat nasal bridge here. And it's not loading, leave it. Yeah, flat nasal bridge, wide open anterior frontal, brachycephaly, like short head, flat occiput, flat nasal bridge, dysplastic low set ears, protruding tongue, upward standing palpebral fissure. We have seen this apicanthal fold. Yes, short neck, excess skin. Can we visualize it anywhere? You can't actually tell, it's fine. Single transverse palmar crease, semen crease, we have seen it. Increased space between first and second toes, sandal gap, yes, we have seen it. Hypoplastic middle phalanx of fifth finger, we have seen this. Congenital malformations, congenital heart disease, endocardial cushion defects, which is VHD, atrial septal defect, patent ductus arteriosus, tetralogy of Fallot. So these are the things. GI malformation, duodenal atresia, Hirschsprung's disease. So these are the things, these are the associative diseases that are associated with this particular genetic condition. Endocardial cushion defects, VHDs, AHDs, PDA, TOF, GI malformation, duodenal atresia, Hirschsprung's. Then neurological and developmental features, hypotonia, floppy baby syndrome, floppy baby, delayed motor milestones, loss of Moro reflex. See once again, Moro reflex. Yeah, you try to drop the baby and the child does this, spread out its arms, pulls the arms back in tight to their chest, starts crying. So loss of that. Atlanto-occipital instability, risk of spinal cord compression, intellectual disability, low IQ, early onset Alzheimer's, which is a well-known association. Hearing and vision defects, conductive hearing loss, 40 to 60% of the cases. Congenital cataracts, glaucoma, strabismus, brush field spots, we have already seen it in the image. Endocrine immune dysfunction, hypothyroidism, recurrent infections, respiratory tract infections. So these three things. Malignancies, increased risk of ALL, AML and transient myeloproliferative disorder. ALL, AML and transient myeloproliferative disorder. Skeletal and growth abnormalities, short stature, hypoplasia of middle phalanx of fifth finger, this one. Hypoplasia of skull base and facial bones, delayed ossification centers. Now antenatal diagnosis. So what do? Triple test, which includes AFP, HCG, estriol, 15 to 18 weeks, where there is low AFP, high HCG, low estriol, low, high, low, AFP, HCG, estriol. And quadruple test includes inhibin A, which is increased, nuchal translucency increased, greater than 3 mm, which is a strong marker. This is at 11 to 14 weeks. Maternal serum cell-free DNA detects trisomy 21. Confirmatory test, karyotyping detects trisomy 21, translocation mosaicism. Fluorescent in situ hybridization, FISH. Quantitative fluorescent PCR. Chorionic villi sampling, amniocentesis, done during different weeks. So CVS done at 10 to 12 weeks, amniocentesis 15 to 18 weeks, similar to triple test 15 to 18 weeks. Then quadruple test 1 week later, 16 to 18 weeks. NT scan done similar to CVS, but I doubt these are done. This one is very common. This one is only for confirmation. FISH, karyotyping, quantitative fluorescence, PCR, amniocentesis. Genetic counseling, trisomy 21, risk increases with maternal age, well known association. Recurrence 1 in 100, subsequent pregnancy. Translocation 4% of the cases. If inherited from parent carrier, higher recurrence risk. Balanced translocation carriers require genetic counseling. So depending upon what mechanism is being followed, it is totally, counseling varies. Mosaicism, risk of recurrence is low. So based on that, we had different kinds of counseling. Now coming to management. So it requires multidisciplinary care where pediatricians, geneticists, therapists all are involved, cardiologists, because endocardial cushion defects Early intervention of physiotherapy, speech therapy, occupational therapy is required. Cardiac evaluation at birth, where echocardiography is necessary. Regular screening for hypothyroidism, hearing and vision problems. Nutritional support and prevention of obesity. Routine vaccination and pneumococcal and influenza vaccines are required. Prognosis, common cause of mortality is the heart disease, so cardiologists need to be included. Rheumatological malignancies are increase the mortality risk. With appropriate intervention, many children achieve semi-independent living. Lifespan 60 years if well managed. And with this, we have completed with major focus on clinical features and a little bit on antenatal detection. And we end the discussion on Down syndrome. Now coming to skin disorders, first we look at something called as Mongolian spot. Mongolian spots are benign congenital dermal we'll look at the image because this is skin, and without an image skin is boring. Yeah, so this is how it looks like. This is how they look like, Mongolian spots. Benign congenital dermal melanocytosis that appear as grey blue macules in lumbosacral region of the newborn. These spots are most commonly seen at birth in Asia. In Asian infants, gradually fade over time. Asian infants, so we can remember Mongolia is in Asia, so Asian infants, and they fade over time. Etiology, pathogenesis, ectopic melanocytes in the dermis. In the dermis, usually where are they? In the epidermis. Melanocytes are in the epidermis, but now they are in the dermis. Fail to migrate completely to the epidermis during the fetal development. The blue-gray color results from the scattered melanocyte deep within the dermis, leading to Tyndall effects. So some physics-related concept being used here. And then clinical features. Location, common lumbosacral, we have seen it already. Shoulders, back and extremities also common. Color, irregular grey blue, slate colored macules. Yes. Non-tender, non-elevated. Self-limiting condition disappears spontaneously by 6 months to 2 years. So 6 months to 2 years. Excessive Mongolian spots are associated with GM1 gangliosidosis and mucopolysaccharidosis. What are the? There should be a name for these. So yeah, there's two complicated names. Let's not go into that. I thought it was somewhat related to that. What are those? The Niemann-Pick disease and all those, spilomegal, those things, but it's not the case. Diagnosis and differentiation. Clinical diagnosis based on appearance and location. Different from bruises, need for biopsy unless associated with metabolic disorders. Management and prognosis. Reassurance to parents. Completely benign and self-resolving. No treatment required. And follow up in cases of widespread and persistent lesions to rule out underlying metabolic disorders. So that is the key thing here. And with this we finish Mongolian spots. Now coming to scabies. Only the management is important, but we also look at clinical features. It's caused by Sarcoptes scabiei var hominis through the close contact with infected individuals and highly prevalent in children, especially in crowded environments. What are the clinical features? Severe pruritus, and there are primary lesions, secondary lesions, and certain common sites. Primary lesions, burrows, grey thread like serpentine lesions with minute papules at the ends. Papules, vesicles and pustules may be present. Secondary lesions include excoriation, eczematized lesions and nodules. Excoriations, eczematized nodules and lesions and nodules. Bacterial superinfections, streptococcal pyogenes could be involved, and that can lead to risk of glomerulonephritis. Common infected regions, web spaces of hands, wrists, elbow, axilla, umbilicus, genitalia, feet and buttocks. Face is usually spared except in case of infants, where scalp, palms or scalp Scalp, palms, soles are also affected in infants. Now coming to management proper. So general management, to prevent the spread, blanket therapy, that is what we have here. All close contacts must be treated simultaneously. So everyone in the family, hygiene, laundering of bed linen, clothing, towels, ironing clothes helps kill mites. And then we have pharmacological treatment. First line treatment, there is permethrin cream applied overnight over entire body from head to toes, from neck to toes, with permethrin 5%. Wash off after 8 to 12 hours, repeat for after 7 days. So before going to sleep, probably over the entire body. Crotameton 10% cream, so 5% is 10%. So infants less than 2 months. Apply twice daily for 14 days. Less effective than permethrin. Benzyl benzoate 25% lotion. 3 applications at 12-hour intervals. And oral treatment, there is ivermectin for epidemics and resistant cases. This is usually first line. Preferred in children greater than 5 years. So what is the dose? 200 microgram daily orally, and repeat dose 7 to 14 days. Supportive treatment, antihistamines, cetirizine, hydroxyzine to reduce pruritus. Antibiotics if secondary infection present, covers streptococcus, staph. Topical emoluments, moisturizers, prevents post-scabetic itch. Antihistamines to reduce pruritus, antibiotics to cover streptococcus, staphylococcus, topical emoluments and moisturizer to prevent scabetic itch. Next, coming to follow up, this one, education and hygiene and re-examination after 1 to 2 weeks. Symptoms may persist 2 to 4 weeks despite treatment. So we have seen the management. We have general management where blanket therapy and hygiene is recommended. Pharmacological treatment where there is first line and oral. First line, there is permethrin, crotameton, benzyl benzoate, and oral treatment there is ivermectin. Supportive treatment includes antihistamines, antibiotics, and topical emoluments and moisturizers. So with this we end this KB section, and now we have erythema nodosum. Erythema nodosum, this is a 3 marker. It's an acute inflammatory hypersensitivity reaction of subcutaneous fat, paniculitis, subcutaneous fat, characterized by tender erythematous nodules, usually over anterior aspect of the lower legs. So let's see an image of how they look like. Did we see scabies? No, we didn't. So let's see that first before we go. Scabies. No. So scabies, yeah, interesting. Now coming back, yeah, erythema nodosum, mostly the lower legs. Yes, lower legs. Erythema paniculitis. So most commonly associated with infection, systemic inflammatory status and drug reactions. Infections include streptococcal pharyngitis, tuberculosis, leprosy, fungal infections. What are the fungal infections? Coccidiomycosis, histoplasmosis. Next, coming to systemic diseases, sarcoidosis, inflammatory bowel disease, and Behçet's disease. And then drugs include sulfonamides, oral contraceptives, and NSAIDs. 3 things: infections, systemic disease, and drugs. And clinical features include multiple tender warm erythematous nodules on anterior anterior shin, thighs, and forearms. Lesions are initially red, indurated, then evolve into bruise-like appearance over weeks. Associated with fever, malaise, arthralgia, fatigue. Diagnosis: clinical examination is usually sufficient. Laboratory tests to identify underlying cause. Skin biopsy if shows septal paniculitis. Treatment: symptomatic management, rest elevation of legs, NSAIDs, might be caused by insects in the first place. And then treatment underlying cause, treat the underlying cause with antibiotics for streptococcal infection, corticosteroids, sarcoidosis, usually self-limiting, resolving in 3 to 4 weeks. With that, we come to the end of the skin disorders. Next, coming to poisoning and injuries and accidents. So first we look at kerosene poisoning. So kerosene poisoning, this is a very nice 5 marker. So kerosene poisoning is one of the most common accidental poisonings in children, particularly in tropical regions where kerosene is widely used for cooking. Toddlers and preschool children are at highest risk, especially when kerosene is stored in improper containers like disposable water or soft drink bottles. So that becomes a problem. So what is the toxicity and pathogen? Kerosene is an aliphatic hydrocarbon with low viscosity and high volatility. So it evaporates easily, which increases the risk of aspiration and pulmonary complications. It does not get absorbed from the GI tract, and its toxicity primarily due to aspiration pneumonitis rather than systemic effects. So from there it goes into the lungs. Factors causing that: volatility, more volatile hydrocarbons increase the aspiration risk, viscosity, lower viscosity, mineral oil, kerosene, they get aspirated easily. Surface tension affects the ease of pulmonary spread. On the fatal dose 30 ml, fatal dose 30 ml cause severe complications and death. Routes of exposure: accidental ingestion, transdermal absorption, intravenous injection. So first one, accidental ingestion, most common in young children. Transdermal absorption from the skin, that is for the neonates, and intravenous injection is rare but drug abuses. Clinical features: immediate symptoms, systemic features and late manifestations. Immediate, there is aspiration pneumonia, violent coughing, tachypnea, retraction and wheezing, crepitations. Violent coughing, tachypnea, retraction, wheezing and crepitations. In case of chemical pneumonitis, there could be hypoxia, respiratory distress. Hypoxia, respiratory distress. Characteristic kerosene odor in mouth and vomitus. Flushing of face, nausea, vomiting. So again, aspiration pneumonia, coughing, tachypnea, retraction, wheezing, crepitations. Chemical pneumonitis can lead to this respiratory distress, kerosene odor, can smell it, and flushing of face and nausea and vomiting. Systemic: headache, abdominal pain, abdominal distension, dysphagia, neurological, restlessness, confusion, convulsions and coma, hypoxia, related cyanosis and respiratory failure. Late manifestation: pneumonitis progression to gives rise to pleural effusion and pneumothorax, chemical hepatitis and renal injury in rare conditions. Radiological changes: chest X-ray after 6 hours, we can see bilateral. So we will look at it. Kerosene pneumonitis, kerosene pneumonitis. You can see how it looks like, and let us see the description here. Bilateral infiltrates, emphysematous changes, pleural effusion and pneumothorax could be seen. Is there blunting of CP angle here? Yes. Serial chest X-rays are required in symptomatic cases. Coming to management, there are general measures, supportive therapy and discharge criteria. General measure: hospitalization for all suspected cases, airway protection for unconscious patient because aspiration. Place the child in left lateral position to prevent further aspiration. Avoid gastric emptying. No emesis, no lavage, no induced vomiting. Do not administer milk or oils. These can this can increase the risk of aspiration. Supportive therapy, oxygen therapy, respiratory support in symptomatic children. Yes, they can't breathe properly, respiratory distress is seen, so oxygen and respiratory support. Monitor oxygen, how much you are giving, what's the saturation. Beta agonist nebulization for wheezing relief. Antibiotics are not routinely indicated. Steroids have no role. Antibiotics no role, steroids no role, but antibiotics only in case of secondary, if secondary pneumonia develops. Discharge criteria: who remain in the asymptomatic for 6 hours. Malnourished children have higher morbidity, mortality. And prevention: store it properly, keep hazardous substances out of children's reach. Parental education about the risks. Prognosis: most cases resolve with supportive care. Severe aspiration can lead to IRDS and respiratory failure. Timely intervention is very, very important. With this, we end the section on kerosene poisoning. OP poisoning, this is actually almost similar in pediatrics, almost entirely similar. So, better to go through medicine for that. General guidelines, same thing, almost similar in pediatrics and medicine. Snake bite poisoning is slightly different, and also scorpion sting is slightly different, so that's why I put it here. And then shock specifically is better to go through medicine or surgery. Surgery part 1, it has very nice description of shock, the types of shock and all that. Hypovolemic and hemorrhagic shock, very nicely given. And drug specifically, as we go through different medicine surgery questions, better to know the uses like that. So, I didn't include it here, but in case I get time in the future, I will include it. But what we would be going through is specifically snake bite management, scorpion sting, and then infant mortality rate. This is a very nice thing, and these smaller topics. And with that, we end the pediatric section. But further other things I am not particularly sure, because I have to, there's a lot of things to do, and this consumes a lot of time, and I cannot commit so much of time. So, for now, pediatrics is online, and I will make sure that every time we have some kind of a link. So, whenever you open this up, there should be a link to this particular section of the video. Anyways, coming to snake bite. So, snake bite overview. Snake bites cause a lot of deaths worldwide, with young children from rural area being most commonly affected. About 3000 snakes species, and 400 of them are, out of 3000, 400 of them are venomous. So, what are the snakes? Cobra, king cobra, crate, coral snakes, vipers, pit viper, pitless viper. So, there is bamboo snake, Russell's viper, and saw-scaled viper, and there are sea snakes, marine envenomation. Then clinical features of snake bite. Envenomation. There are local effects, systemic manifestation. Local effects include pain, swelling, tenderness, blister formation at the bite site. At the bite site, pain, swelling, tenderness, blister formation, nausea, vomiting, abdominal pain, tissue necrosis. Systemic features depending upon what kind of venom it is. So, there could be neurotoxicity, coagulopathy, rhabdomyolysis, and cardiotoxicity. Neurotoxicity: ptosis, diplopia, bulbar palsy, dysarthria, generalized weakness. In case of coagulopathy, there could be bleeding from bite sites, epistaxis, gum bleeding, intracranial hemorrhage. So, bleeding, a lot of bleeding. Rhabdomyolysis seen in Russell's viper, sea snake. Muscle pain, dark urine, ATN, acute tubular necrosis. Cardiotoxicity and shock: direct cardiotoxicity, hemorrhagic shock, myocardial toxicity. So, cobra, crate, sea snake for neurotoxicity, vipers, Australian elapids for coagulopathy, Russell's viper and sea snake for rhabdomyolysis. Then coming to investigations, CBC, all the counts and hematocrit, urine analysis for kidney related problems, electrolytes 1, creatinine ECG for this one, what is kidney related, and also rhabdomyolysis, very helpful, and 20 minutes whole blood clotting time for coagulopathy, greater than 20 minutes hemotoxic envenomation, 20-minute whole blood clotting time. And coming to the management, first aid management, do not cut, suck or mechanical suction do not use mechanical suction devices, do it right. RIGST, reassure, immobilize the affected limb. GST, get to hospital. T for tell the doctor about symptoms. Pressure immobilization for neurotoxic, not for cytotoxic venoms. For neurotoxic, the neurotoxicity includes these things: ptosis, diplopia, bulbar palsy, dysarthria, generalized weakness. In those conditions, pressure immobilization. Hospital management, vitals should be monitored, IV and oxygen support. Like every other emergency, whole blood clotting time, which was mentioned earlier here, greater than 20 minutes, it's hemotoxic envenomation, tetanus prophylaxis, broad spectrum antibiotics, and antivenom therapy. Polyvalent ASV neutralizes these things: cobra, Russell's viper, crate, saw-scaled viper venom. These 4: cobra, Russell's viper, crate, saw-scaled viper venom. Initial dose: Russell's viper neutralized by 8 to 10 vials of ASV, 8 to 10 vials. Total dose 25 vials. I won't remember this, very hard to remember. 25 vials. Russell's viper is 8 to 10 vials. Hypersensitivity. So a hypersensitivity test before ASV administration, skin test 1:100, saline dilution, and conjunctival test 1:100 in lower conjunctival sac, 1:10 over here, 1:100 here. That means more of over here, more of concentration. Intravenous ASV over 1 hour. Epinephrine kept ready just in case of anaphylaxis. So antivenom therapy, we need to know the vials, 8 to 10, total dose at 25 vials, and hypersensitivity testing. Next, coming to the observation and response monitoring, improvement seen in 30 minutes in case of neurotoxic envenomation. Coagulation dysfunction corrects in 3 to 9 hours. Neurotoxic within 30 minutes, coagulation 3 to 9 hours. BP improves within 30 to 60 minutes in case of shock. Coming to criteria for repeat ASV doses, persistent blood coagulability after 6 hours. So it should be normal after 6 hours, right? It should start becoming normal. But even then, if it is a problematic this thing, even after 6 hours, you give repeat. Brisk bleeding after 1 to 2 hours. Deterioration of neurological and cardiovascular signs after 1 to 2 hours. So within 30 minutes, it should get better. But if it gets bad, this and along with this or this within 1 to 2 hours, then repeat. Coming to supportive management, neurotoxic envenomation, mechanical ventilation for bulbar and respiratory paralysis, neurotoxic envenomation, mechanical ventilation. Then neostigmine could be used 0.05 mg per kg over 30 minutes for 5 doses. Coagulopathy and shock, FFP, platelet transfusion, packed RBCs, IV fluid resuscitation in acute renal injury, surgical debridement in gangrene cases. So timely ASV is very important. Severe envenomation requires prolonged ventilation and dialysis because kidneys are affected. Education or snake identification. Let's see snake identification by ourselves once. Cobra, crate, Russell viper, saw-scaled viper. Yeah, the big four. You can see the image: Indian cobra, the king cobra, saw-scaled viper. You can see how it looks like and differentiated from is darker color from Russell viper. And common crate is black. Black meaning it is different. Actually, you can't actually tell. is common grade, but you can see how it is different. They have the hood. This one I can't see it clearly, but anyways, you get an idea. It is important. Now with this we end the discussion on snake bites. Now we go to scorpion sting. Scorpion sting will be mainly looking at a little bit of lag. We are looking at a little bit of lag. So let me drink some water. Scorpion sting overview. Scorpion sting envenomation is an acute life-threatening medical emergency. Acute life-threatening medical emergency, especially in tropical and rural settings of South and Central India. 1,500 scorpion species have been identified. 30 are able to produce severe neurotoxic and cardiotoxic envenomation, and the names are these: Mesobuthus tumulus, Palaminus swamerdami, Indian red scorpion and Indian black rock scorpion. Pathophysiology before we go into the details. Scorpion venom is complex mixture of toxic proteins including neurotoxin, phospholipase, hyaluronidase, histamine releases and serotonin. So a lot of things. So in our snake one we had this is specific, right? This specific, but this is not the case here. Everything is combined, and overall it stimulates alpha receptors. Because of that we have hypertension, tachycardia, myocardial dysfunction and pulmonary edema. Neurotoxic effects by activating sodium channels lead to autonomic dysfunction. Excessive serotonin release causes pain at the sting site. So one was alpha mediated hypertension, tachycardia, myocardial dysfunction and pulmonary edema. Next we have neurotoxic issues because of inactivation of sodium channels and leading to autonomic dysfunction. Then we have excess serotonin leading to pain at the sting site. We can finish this. Clinical features. Local symptoms: severe excruciating pain at sting site, starts immediately, peaks in 5 hours. Subsides within 1 to 2 days. No visible skin changes except for pain and paresthesia. Positive tap test. Systemic manifestation: there is autonomic storm. That is the main one. Autonomic storm. Parasympathetic followed by sympathetic. Parasympathetic signs. So we know what the parasympathetic signs are: vomiting, profuse sweating, hypersalivation, bradycardia, ventricular arrhythmias, hypotension, priapism. Sympathetic signs: hypertension, tachycardia, myocardial dysfunction, pulmonary edema. This is alpha mediated, shock and cold extremities. So first is parasympathetic, then sympathetic. Very characteristic. We have never seen this. Only in case of scorpion we are seeing this. Clinical grading of scorpion sting severity. So grade 1 through grade 4. Grade 1 is local pain and paresthesia at sting site without inflammation. So without inflammation. Second one, radiating pain and paresthesia in affected limb. Third one, cranial nerve dysfunction, blurred vision, involuntary movements, eye movements, slurred speech, tongue fasciculation. So head region is affected now. Last one, cranial nerve and somatic skeletal dysfunction. So now even along with the head, even the hands, feet, everything is affected. Restlessness, fasciculation, epistatonus. So those are the 4 grades. Grade 1, local pain and paresthesia without inflammation. Next is radiating pain and paresthesia affecting that particular limb only. Next, head region, blurred vision, eyes, movements irregular, slurred speech, tongue fasciculation. Last one being cranial nerve and somatic skeletal dysfunction, restlessness, fasciculation, epistatonus. Next, coming to the investigation: chest X-ray to detect pulmonary edema, ECG to assess myocardial involvement. So myocardial involvement, what do we see? Peak T waves, ST elevation, prolonged QR, low voltage complexes. This means it is bad. Echocardiography to detect left ventricular dysfunction. Echo to detect the dysfunction of the left ventricle. To detect the dysfunction of left ventricle. Yes. Management. So treatment. General supportive measures. There is pharmacological treatment and scorpion antivenom. So general pain relief. So local site, that is grade 1. So for that, in that particular case, meaning for just for pain, paracetamol, ibuprofen, wound cleaning and tetanus prophylaxis. Severe autonomic symptoms requires intensive monitoring. Maintain fluid balance to correct loss due to vomiting. So we have seen this is one of the parasympathetic signs. Frequent suctioning of oral secretion. This is a parasympathetic sign. Intubation and mechanical ventilation if airway protection is needed. So this is also a parasympathetic. So for that specific, like secretions and all those, this clog the airway. Pharmacological treatment. Midazolam infusion for sedation and muscle spasticity relief. Sedation and muscle spasticity relief. Midazolam infusion. IV fentanyl preferred over morphine. IV fentanyl preferred over morphine. Prazosin, alpha 1 antagonist, reduces hypertension and vasoconstriction. So what's the dose? 30 microgram per kg per dose, repeated over 3 to 6 hours until extremities warm. Avoided in hypotensive dehydrated patients. So in this particular case, the BP is already low, it becomes more low, so that's bad. Dobutamine infusion 5 to 15 microgram per kg per minute. So that is for myocardial dysfunction. So hypomotility, hypocontractility in that particular case. Sodium nitroprusside 0.3 to 5 for severe hypertension. Antivenom reverses venom effects and neutralizes circulating venom, reduces symptoms and the need for sedatives. Scorpion specific FAB equine antivenom, this is the name. Scorpion specific FAB equine venom should be given for grade 3 to grade 4 and observation for 6 hours before discharge. So let's see grade 3 to grade 4 again. There is head involvement, blurred vision, involuntary eye movement, slurred speech, tongue fasciculation, then cranial nerve and somatic skeletal involvement. So pharmacological treatment, once again we'll see muscle spasticity, for that and for sedation we give midazolam, IV fentanyl or over morphine for pain, and prazosin, that is alpha 1 antagonist. This reduces hypertension, vasoconstriction, which is a sympathetic sign. Avoid in hypotensive. Dobutamine for myocardial dysfunction and sodium nitroprusside for severe hypertension, and the name of this one is scorpion specific FAB equine antivenom for grade 3 and grade 4. And with that we finish this one also, scorpion sting, and these I have already mentioned. Next, coming to, we have almost 1 minute. Let's try to do this. Infant mortality rate. This is defined as number of deaths of infants in number of deaths of the infants in the numerator divided by under 1 year of age per 1000 live births in a given. So total number of births, live births. It is a key indicator in healthcare equality, quality, maternal and child health services and overall socio-economic development. Like every country has its own infant mortality rate, and that determines what kind of healthcare the country has. If a country cannot save the young, the child, the newborn and the mother, that means it has a very bad healthcare. What are the factors? Maternal health and nutrition, neonatal factors, socio-economic and environmental factors, healthcare system related factors. So first, maternal health and nutrition. So malnutrition, it is important risk factor for these things: low birth weight, preterm infants. There are maternal infections like HIV, syphilis, torch. This can cause congenital anomalies and neonatal complications. Lack of antenatal care. is in undetected complications and poor birth outcomes. Neonatal factors, prematurity and yeah, I think better to take a break now. We have finished the first factor, because anyways this is going to be this one big thing. Then after that we have the last section wherein there are some palsies and all that. Yeah, where is it? Miscellaneous section. Yeah, so we need to do all these things also, so we'll combine that in the next session, and with that we shall be ending our pediatrics, but for now it's a break. Son. Yeah. So let's continue. Neonatal factors. So prematurity and low birth weight, major causes of neonatal deaths, and birth asphyxia and asphyxia and trauma also being a major cause. Neonatal infections like sepsis, pneumonia, meningitis, tetanus also can cause infant mortality. Then congenital anomalies like heart defects, neural tube defects, all these contribute. These are neonatal factors. We already seen maternal nutrition and health, maternal health and nutrition. It's coming to socio-economic and environmental factors. Poor maternal education is linked to higher infant mortality due to lack of awareness of hygiene and nutrition. Poverty inhibits access to health care, clean water and sanitation. Inadequate immunization coverage increases the risk of vaccine preventable diseases. Poor sanitation, lack of safe drinking water contributes to diarrheal diseases and malnutrition. So all these points are self-explanatory. There's like in community medicine, so basic things don't need a lot of explanation. Coming to healthcare factors, healthcare system factors: inadequate care, prenatal, postnatal, shortage of labor, skilled labor and facilities, and limited access to essential medicines and vaccines. So we have finished the factors that affect the infant mortality rate: maternal health and nutrition, neonatal factors, socio-economic and environmental factors, and health system related factors. Measures to reduce infant mortality rate. So first one, improving maternal health. Second one, strengthening neonatal health. Third one, immunization and infection control. Fourth one, addressing malnutrition, feeding practices, enhancing infrastructure, socio-economic interventions. So it looks like we are going from like the ones that can be changed at a microscopic level at a broader section. So microscopically, like improving from the beginning, maternal health can be improved with proper ANC, regular checkups, early detection and management of high risk pregnancies, iron and folic acid supplementation to prevent anemia and birth defects, encouraging institutional deliveries with skilled birth attendants. Strengthening neonatal care, essential newborn care, expanding NICU and newborn resuscitation services. So newborn care, like as soon as the child is born, in that particular condition, immediate exclusive breastfeeding, thermal regulation with KMC and skin to skin contact, and early detection and treatment of neonatal sepsis.